When I first started putting people on GLP-1, it was like this lifesaver. People lost 50, 60 pounds. And guess what? They came off of the GLP-1 and they gained that weight right back. It's not meant to be something that they're stuck with for the rest of their life.
Welcome to the Dutch Podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jaclyn Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. This information is not to be interpreted or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, and treatment. Hi there. I'm so glad you're with me for this week's episode of the Dutch Podcast. This week, we're going to talk about one of the hottest areas of medicine, GLP-1s. And while there's so many physicians out there prescribing GLP-1s, I think when you hear from our guest today, you're going to realize that the way we do it in functional and integrative medicine is a little bit different. It's with a little bit more forethought. It's with a little bit more testing. It's a little bit more just understanding of how you can protect people from side effects and downstream negative effects of a GLP-1, and ultimately how you can fix the root cause that got them there in the first place. We're going to cover all of this, along with talking about some of the newest, hottest drugs available on the market. And most importantly, what do we do when it's time to get someone off of a GLP-1? That's not a conversation that we have very often, but certainly we don't want people on these forever. So how can you ramp off safely, minimize the weight gain that can come, we know, in clinical trials with getting off of GLP-1? And I'm really excited to hear our guest point of view. Our guest today is Dr. Bindiya Gandhi. She's a double board certified family and integrative medicine physician and founder and medical director of Revive Atlanta MD. She's got over a decade of clinical experience and she specializes in obesity, insulin resistance, and metabolic dysfunction with a particular focus on the hormonal drivers of weight regulation, including leptin resistance, GLP-1 signaling, and more. She was an early clinical adopter of GLP-1 therapies and she's treated thousands of patients and developed a systems-based approach that really combines the precision diagnostics like we talked about, optimization of the gut microbiome, and targeted nutrition to make sure you're really addressing the root cause of weight loss or resistance, whether or not someone's getting on a GLP-1. Her work centers on reframing obesity as a neurohormonal signaling disorder and really replacing shame with science in the conversation around sustainable weight loss. I'm going to go ahead and bring our guest in, and let's go ahead and get started. So, Dr. Gandhi, I'm so excited to have you with us today. And I'm really wanting to dive into the topic because it's a very high interest topic that I know people really want to dive into straight away. But before we do, I always love to ask, and just to get to know you a little bit better and let our listeners get to know you a little bit better, tell me how you found your way into functional and integrative medicine from the conventional model you were trained in.
Well, first of all, thank you so much for having me on today. So, probably like most practitioners, it was my own personal journey. I remember thinking I was doing everything right in residency. I was eating well, I was exercising, I was meditating, doing yoga, all the things that we're supposed to be doing. And yet, my own health failed me, right? Around the time I was like I think I just maybe had turned 30 or late 20s and had developed a lot of acne. I had a rash on my face that wouldn't go away. I had irregular cycles. I had chronic headaches, and you know, I- everybody was like, "Oh, not a big deal. This is just aging. It's kind of normal." And I was like, "This is not normal." And it wasn't until that rash on my face didn't go away, and it literally took 2 years. And I had been to the dermatologist. I had all the medications. I had the antifungals, the antivirals, the steroids, the you name it. I had been on everything and I was desperate. And everything I tried, the rash would go away and it would come right back. And it was obvious to me, right? And I didn't want to just cover it up with makeup.
Yeah.
And I kept asking, could it be a nutritional deficiency? I kept asking questions. They were like, no, no, you're fine. Nothing to worry about. And then the one thing that really bothered me was like, I was like, I need more answers. Something's not right. We've been doing this for 2 years and it's not working. Finally got in with a allergy immunologist because I kept thinking, is this an autoimmune thing? And they're like, no, you're just a stressed out resident. We don't need to do blood work. You're fine. And that's when I was like, okay, this is not working. Like I'm trying. And at the time, I was also really interested in Dr. Andrew Weil and integrative medicine. And so I was fortunate to find an integrative and functional medicine doctor and did some testing. Long story short, found out I had celiac. And so life changed when the minute I cut out gluten. And so, yes, I thought I was doing everything right. But at the time, I was also eating a lot of whole wheat, everything, whole wheat pasta, whole wheat bread, because that's what I thought you were supposed to be doing. And so here I am, 14, 15 years later, and life is different. But I'm so grateful for my own personal journey because I understand being a patient and I understand what patients go through. So I can relate to them on a very deeper personal level because of that.
I appreciate you sharing your story with us. It's so interesting to hear. It's like I have a same story in my background. It's like that story of like you have a problem, you seek the healthcare system that you grow up in and trust and for you work within. And then find that, once you run through the algorithms, there's, like, nothing there. Like, no one is spending the time, which partly is a model issue, right? Because no one has any extra time to think a little bit deeper about, like, what could be happening physiologically, or you have this disparate. We talk about this with friends all the time now. We have aging parents where they see you have high blood pressure and you see a nephrologist and a cardiologist and a PCP, but, like, no one's really putting things together, and that's just how our model's built. So, I mean, it's just so fascinating to hear your story, to see you come into functional integrative, which is like kind of pulling it all together again.
Yes, and I think even this is why I love what I do, especially with my patients, because instead of having them to go to like 20 different doctors, I'm essentially managing everything for them and I know the whole picture and I could connect the dots and yes, this is what's needed for sure.
Well, it brings me to like a place of real excitement to talk about today's topic, which is GLP-1s and metabolic dysfunction and weight, because I think when we look at it through this lens that you and I are looking through and speaking from of whole person medicine and prevention, I think there is a risk inherent with GLP-1 use that it becomes like the hammer for all nails and it becomes something that's like given to patients without a lot of thought or management about how and why and how long and how you're getting it off. And we're going to get to talk about all that today.
Yeah, for sure.
So, in your view, I want to start by talking about just metabolic dysfunction for women specifically. What is like the single most unappreciated driver of why metabolic dysfunction happens specifically for women?
You know, we are very complicated.
We
we
sure are.
we have a lot of hormones, and this is the probably the biggest thing that makes it harder for a woman to either maintain weight or lose weight, and especially as we go through the perimenopause, menopause years. So, unlike men, we're dealing with estrogen, progesterone, testosterone, along with cortisol. A lot of us are mothers. I keep saying we're in the sandwich generation. We're taking care of our older parents and we're taking care of our kids. So we also have a lot more of our plates, along with taking care of ourselves somewhere in the mix, right?
Yeah, to
So
get
our
time.
yeah. So our hormones are fluctuating, literally from the time we start having a period when we're what 12, 13, whatever age that is. And then, we go through having babies and going through the years where we're super fertile. And we go from having babies straight to like what we call perimenopause. And again, it's all the hormone fluctuation and changing it and the rapid changes of the hormone fluctuation
Mm,
and how that really impacts our metabolism. But stress is a really big one because I feel like women are dealing with chronic stress probably even maybe before they're trying to conceive, right? So all these hormones are talking to each other, working with each other, and then also impacting our metabolism. And this is probably why women struggle more than men.
definitely. Now, before we get into the nitty gritty science, like I hear you talk a lot about insulin resistance, which I think most people know about insulin resistance. But I also hear you talk a lot about leptin resistance. And I want to make sure our listeners, before we get into it, are really oriented to what leptin is and why it really matters when we talk about weight. Can you share a little bit about that with us?
Oh my God, I get really excited about leptin. So, leptin is a hormone that's produced by your fat cells. It communicates with your brain. It lets us know if you're hungry, full. Do you need to eat more? Do you need to eat less? What happens over time is women, we've been dieting since we've probably been 16, whether you realize it or not, right? And fluctuating hormones have really changed our metabolism by impacting our leptin hormone. When the body thinks you're starving, it's going to hold on to food, right? It's going to hold on to that fat storage. Even though there's a ample storage available, it's going to slow down your metabolism. And this is what leptin is all about. So I get really geeked out about leptin because everybody knows everything about insulin resistance, but nobody really knows how leptin impacts our metabolism in the long run.
So, how are they different, like insulin and leptin resistance?
Yeah, great question. So, insulin resistance, we kind of know, it's impacted by your blood sugar, kind of associated with the insulin release in the pancreas when we eat carbohydrates or sugar, essentially, right? Leptin is a little bit different. Our cells get the memo. Are you full? Are you hungry? So, typically, when we eat, we should be getting the memo. It's time to stop eating, right? For some people, they don't get the memo that they need to stop eating. And sometimes this is why they overeat. Or in other reasons, this is also why sometimes people will eat and then like an hour later they're like starving again. I don't know why, but I need to eat again, right? That communication is off between the fat cells and the brain.
Okay, that's cool. So I know like we're going to be talking a lot about GLP-1 receptor agonists. These have become one of the fastest growing prescription categories in medicine. I think everyone at this point has heard about GLP-1s. And actually the data is so interesting, like generally 15 to 22% body weight reduction in clinical trials, although you have like Retta, which just had what, 38% reduction in weight. It was a massive amount in a more recent clinical trial. And with women, these medications do end up just interacting with all of our other hormones in ways that research hasn't fully elucidated, clinical guidelines haven't really addressed. So when a patient comes in and they're dealing with like insulin resistance and leptin resistance, and you're thinking about a GLP-1 receptor agonist for her, are those two mechanisms like separate in your mind, or are they connected in the way that the GLP-1 maybe helping her?
It kind of both, right? So GLP-1s, we know that they are decreasing your appetite. We also know that you get full faster, right? There's a lot of amazing benefits. It started off as diabetic medication, right? And this is why it really does help with the blood sugar, controlling of the blood sugar. But it also helps on the leptin hormone, right? As well. So we tend to know, and this is one of the reasons why I know who's a good candidate for GLP-1s versus not. I'm very lab data oriented and I look at blood sugar levels and your insulin levels and also your hemoglobin A1C, but I also look at your leptin levels. And so when I tend to see leptin levels being really, really high, I know that these people who have higher leptins may also benefit from being on a GLP-1 medication. And I tend to notice that when I put them on the GLP-1 medication, that leptin hormone comes down. This is also something that I use clinically to determine who should come off of the GLP-1 and when it's appropriate to come off, right? I look at their leptin hormone. When I notice that their leptin hormone is closer to 7 to 10, I know they've lost enough weight, their metabolism is in gear, that maybe we could try getting them off of the medication, right? It's not meant to be something that they're stuck with for the rest of their life.
That's such an important question, and we can go right there because I think, I definitely wanna talk with you today about getting off of GLP-1s. I think not a lot of people have done it because people are, like, loving it. They wanna
Sure,
be on it
for
forever.
sure. Yeah.
And you're seeing it used in populations of people who maybe wouldn't have met criteria for it because it's, like, available through online pharmacies and things like that. But what has your experience been in women coming off of GLP-1s? Like, what has their experience been? What have you observed medically? What's the culture around it like?
So let's talk about it all because I will tell you initially, when I first started putting people on GLP-1, it was like this lifesaver. People lost 50, 60 pounds.
Right.
And guess what? They came off of the GLP-1 and they gained that weight right back. Okay. I've seen that
Mm,
happen. And so what I do differently is I work with them and heal their gut. We know that there's a link between the gut microbiome and GLP-1, especially when we're trying to come off of it. And especially if we don't want to get back on it. Right now, I have some people that will cycle on and off of it during certain time periods. But what we tend to notice is the people that do really, really well off of the GLP-1 is people that have also preserved their muscles, right? Because muscles also impact your metabolism. So in our practice, we really encourage that people are eating high protein diets and they're strength training. They're really building that muscle. We notice that when people just get on the GLP-1 medication, they're going to lose a lot of muscle. So yes, they're losing weight, but of that weight, it's majority muscle. So the first thing that we do is we want to prioritize protein and preserve that muscle. Now, the other thing that we're also doing is we want to make sure that their microbiome is really healthy because we want our GLP-1 is actually produced in our gut, right? Many people don't even realize that. So
Yeah, when you think
that's
about, like, the fecal transplant data, I mean, it's probably because you were getting, like, GLP-1s through someone else's
correct.
feces. I mean, it's, like, totally amazing. Yeah.
So that's what we do in our clinic. We want to make sure that people are optimizing their own GLP-1 production and we make sure that their protein is high, but then we start working on their gut while they're working with us. And that means we're making sure they're getting enough fiber, polyphenols. We're really kind of making sure that we're stimulating that GLP-1 naturally. So when they come off of it, and I'm also looking at their leptin levels, when it's time to come off of it, we're like, everything is working right. Everything is in alignment. You can come off of it. Some people still might gain a couple, 2 to 5 pounds because obviously there's a change in appetite that happens. But giving them that buffer is perfectly fine because we know that while they're maintaining all the good habits that we've taught them, that they should be fine off of the GLP-1 medication.
So, let's get back to talking about women and women's hormonal status. You have, like, cycling females, perimenopausal females, postmenopausal females. Are there changes in the way women respond to GLP-1s based upon hormonal status?
Yes, actually there is. So it does matter if they're on hormone replacement therapy as well as GLP-1s. We do notice, again, clinically, I've seen this in practice that I do need to adjust their hormones appropriately as they continue to lose weight. So sometimes I'm bumping up their HRT or MHT now, menopause hormone therapy, along with their GLP-1 medication. So when they start losing weight, um, we do notice that sometimes women will have breakthrough bleeding and some of these other things while they're on hormone replacement therapy. So we want to make sure that we adjust that accordingly. So it kind of does matter what phase of life they're in, especially in the menopausal years, along with hormone replacement therapy medication.
That's so interesting because I think about that, like, adipose, especially postmenopausally, is quite a big source of estrogens compared to, I mean, we don't have ovarian function anymore. So you think about women who are losing a lot of adipose, that it could absolutely affect their hormone status. And I know there were a couple of studies, I'm not as well versed on this data, but when women were on MHT and estrogen replacement therapy, they tended to lose more weight on GLP-1s compared to women who were not.
There's actually a study out of Mayo Clinic that just showed that women actually do better when they're both on MHT and GLP-1 in the long term for weight loss versus just GLP-1 alone or versus just MHT alone.
So you talked about when women come in, you mentioned a lot of the metabolic workup that you do. Are there other labs as well that you like to look at before you consider putting someone on semaglutide or tirzepatide or whatever the GLP-1 of choice is?
I do. I look at inflammatory markers as well. We didn't really talk about that, but I do look to see like to have a lot of inflammation. I'm also looking at thyroid is really big, and knowing if I need to adjust their thyroid medication on or off of GLP-1 too. So just kind of like getting their whole picture, what their risk factors are. But I'm very data driven, so I'm looking at
No.
inflammatory markers. I'm looking at so many different things to understand what's really happening with their overall health.
I love that. I mean, I think one question that comes up a lot too is that some people do tremendously well on GLP-1s and other people seem to kind of plateau a little bit sooner. Have you seen trends with all of the data and the tracking that points you in the direction of why one woman versus another may respond better to it?
Yeah, and this is was my, like, number one curiosity, like, a couple years ago because I
Yeah.
was like, "Why are people losing weight and some people are not, and they don't lose weight until they get to a higher dose," and I realized it all goes back to their microbiome and their gut, and so once that clicked in my brain, I was like, "Oh, that's the aha moment, of course." That's why we want to, produce that natural GLP-1 in the gut. I see a lot of patients that have, like, dysbiosis or an imbalance of good and bad bacteria. They have trouble losing weight, but we're also for some people, they have inflammation in their gut, and there's some other things that still need to be worked on. When their gut is also healed or very, where it should be, essentially, losing weight on GLP-1 is a lot easier.
It's really fascinating, the connection to the gut with, I mean, really every health condition. You look at your rash, right? I think it's like, who would have thought that was originating as celiac in the gut?
In therapy, like some of my patients that do really, really well on hormone replacement therapy, um, it's because their gut is optimized and healed versus like a patient that has a lot of dysbiosis. And I'm like, why are you we're doing everything to optimize your hormones, but if you don't feel good. So it always goes
We
back
talk
to
about
that.
that all the time at Dutch. I mean, we have a couple of things, like we have a marker on our report called indican, which is a urine marker of gut dysbiosis. It's like a byproduct of some dysbiotic bacteria that we can pick up in urine. which is not specific, but if I tell people if you see it elevated, you definitely should be looking at your patient's gut for sure. And then we also just know that connection with estrogen metabolism, the fact that you have phase 1 and 2 in the liver, but phase 3 is gut. It's all about having the right gut microbiota and having enough fiber that you can actually carry that packaged up estrogen out of the body. And actually, that brings me to a point that I think is also so important around gut health and GLP-1 use or weight loss, especially rapid weight loss, which is the fact that most of our toxins are fat soluble, like in the world. And so that's also stored in adipose tissue, which when you burn it, when you are like getting rid of adipose through weight loss, you are releasing that into the body again to be processed and excreted. And think of it as like stored. I always tell people like stored in a closet. It's like when you finally like unpack all that closet and dig through all the old stuff that you used to shove in there, you've got to deal with it and sort it and get rid of it. And that is all dependent upon gut health as well. It's the same beta glucuronidase that we talk about with estrogen.
That's right. That's
That's
right.
critical for toxins.
Correct. And this is why, again, I really like looking at the gut when I have people on not just hormone replacement therapy, but also when we're on GLP-1, because everything is so interconnected. And this is why I love what I do, because everything is makes sense in my world.
I feel the same way.
We'll be right back with more. At Dutch, we empower providers to confidently integrate functional hormone testing into their practice. Registered Dutch providers gain exclusive access to hormone education courses, including our Mastering Functional Hormone Testing course. This course shows providers how to effectively use Dutch testing to assess and interpret hormone levels in both male and female patients. You'll learn more about hormone testing basics, including estrogen, progesterone, and androgen levels, as well as adrenal function and HPA axis health. Register for this course on the homepage of your Dutch provider portal, or become a Dutch provider today to get access. Welcome back to the Dutch podcast.
So I know we've talked about gut, but another thing that you mentioned earlier that can impact whether women are able to lose weight or not is cortisol and that kind of chronic activation of the HPA axis. And we know it disrupts the hormone environment. And I think people kind of recognize when you're under stress. Well, some people gain and some people lose, right? Some people become catabolic and they just drop weight. But can you go beyond a little bit or like dig a little deeper to help our listeners understand the connection between stress and weight?
Yeah, for sure. So cortisol, 100% is impacts your leptin level, your leptin hormone, but it also impacts your blood sugars and your insulin level, right? Insulin resistance. So a lot of times when people are stressed, right? Let's talk about an acute stress, right? So you break your leg or, you get in a car accident, you have some acute stressors. What's supposed to happen physiologically is the cortisol is supposed to spike up, and that's normal, right? We tend to see that blood sugars will spike up, like the body is just in a fight or flight mode, right? The problem happens when you've been on this chronic stress for a period of time, 3 to 6 months or longer. And I use the analogy of the bear is chasing you now for 3 to 6 months, and now you don't know how to function. What ends up happening is we tend to see a lot of dysregulation in your blood sugars. We also tend to see that your body's like you're trying to hibernate. Your body's trying to protect yourself. Everything goes into storage mode, right? Your metabolism slows down. You just want to sleep. You want to hide. You want to like get away from this bear but you just want to hibernate, right? And so when all that's happening, your metabolism slows down. You're going to be in storage mode. Your body's like, I don't know when you're gonna get fed again, right? So let's make sure that we preserve everything you have. You're burning less calories. So all these things are happening because it's trying to preserve you, because cortisol is high, right? Cortisol is like it's taking over essentially. Even your sex hormones, like testosterone will drop, DHEA will drop, progesterone drops. It's because cortisol is the primary and everything else becomes secondary.
Yeah, when we think about the hormone hierarchy, it's like one of the first. You have glucose and cortisol that are really, they run the show, right? So if they're not in balance, everything else kind of suffers downstream.
Correct.
So I always had a group of patients in my practice. Many of them were actually fitness instructors, but they were women who were kind of getting into that like 30s, 40s age. They are doing everything right. They work out all the time. They are eating pristine diet. Like they recount their diet to you and you're like, I just have no idea what I could possibly give them for advice because everything is so spot on. But then they are finding that they're like starting to have weight creep on. What is up with that in that time of life?
So a lot of things are happening. I see this is like the bread and butter of my
I
practice.
know. I know
And the
we that's like they're like what oftentimes we would call like the wealthy well. It's like the women who are optimizing their health, and it's a lovely group of people to work with where they don't have a acute disease, but they're not in optimal health, and it's such a tricky spot.
You know what I tend to notice is this is where I start optimizing their lifestyle. So yes, I know they're doing everything right and perfect, but usually I'll find things like maybe they're drinking a little bit too much, right? Maybe they're
Mm.
consuming a little bit more alcohol. Sleep is a big thing. Stress is a big thing. So kind of like pinpointing specifically what we could optimize on really does help. But a lot of it is hormonal. I tend to see, specifically in my practice, because of that chronic stress, it does impact the thyroid, which also impacts the metabolism. So most of these women also have what I call low T3 syndrome, essentially. So we end up supplementing them with some T3, which helps their T3 come up, which also then this is also impacted by cortisol and stress, and so that also helps their metabolism a little bit. But it's a little bit of everything. That we do to kind of get them over the hump. Some of them also really need some hormones, right? And so I'm giving them a little bit of progesterone, or we're really supporting their adrenals, or, we are detoxing. One of the things I like to do, especially if their estrogen tends to be higher, they're estrogen dominant. I'm kind of like detoxifying phase one, phase two liver with, using dim and some of these other supplements to just make sure that things are optimized. So usually I'm able to potentially pinpoint something that we can work on with these women to optimize their overall health.
Are there lab patterns that you, like, see a lot of? Because 'Cause I'm hearing you talk about, like, you have thyroid, you have cortisol, you have sleep disruption. We talked about hormones, talked about Dutch, talked about, like, hormone metabolism. Are there patterns that you typically see across these women?
Kinda, but not really. I feel like what I've learned over the years, obviously every single woman is very unique and different, but I do tend to see, or maybe because they're coming to me in my practice, I'm seeing a lot of women have that low T3 syndrome. I do see a lot of that. Especially in my high performing, high achieving women. It's like the body's compensating somewhere, right? Um, that is common. The other thing that I tend to see really common is progesterone. Progesterone tends to be one of the first thing that declines in my perimenopausal years, and that does impact sleep. And we know that when we're not sleeping well, we tend to have blood sugar dysregulation. When we're not sleeping well, our cortisol's off. Like all these things tend to happen when we're not sleeping well. And so progesterone is usually one of the things that I'm probably leaning towards first in a group of my women. And then testosterone, because of that chronic stress, I tend to see a lot of low testosterone. So a lot of times,
Mhm.
yes, they're pumping iron at the gym and they're doing all the things they're supposed to. But if their testosterone is low, it's like they're not really building that muscle. Like they're hitting a wall. They're lifting weights and that's awesome, but they're not really making natural growth hormone. They're not really preserving their muscle mass. And so again, optimizing their testosterone also tends to help.
Yeah, that makes a lot of sense. It's such a compliment like we started with, women are complex, right?
It's
Our
so
hormones are
complex.
complex.
Yeah.
It's tough. We just wish there was an easy model. Well, let's dive into GLP-1s a little bit more because this is an area where the field is really rapidly evolving. We have an oral option available now that's moving through phase 3 trials. You have these triple agonists like the retatrutide, which has like really massive results in phase 2 trials. And I think the other thing that's so interesting is we're seeing this expansion in use in research. So it's going well beyond, like you'd mentioned, diabetes initially
Yeah.
into weight loss and obesity, but now cardiovascular disease, renal disease, neuroinflammatory disease. I mean, the way it's being applied in clinical research is really amazing and very fast moving. And I think part of it is, like you said, it touches upon so many different mechanisms in the body and
Yeah.
inflammation and chronic inflammation. Tell me, what are you watching most closely in all of the emerging research right now?
I love every aspect of GLP-1. So I love that it's reducing fatty liver. It's, preventing cognitive decline. Anything essentially associated with obesity, right? The links to potentially reducing the risk of cancers, all these things that we can mitigate by losing weight and being at a healthier body mass index is helpful, right? So all those things are helpful. One thing I'm really excited about, I just heard about a study, was it this week or last week, about asthma. There's a link between asthma and GLP-1. When patients are taking GLP-1s and they have asthma, they're using their inhaler less. And that's all, again, decreasing inflammations. Again, this to me is also very exciting because we're going to find more studies like this emerge and more data come through that is is showing that it's not just blood sugar, it's not just the weight loss, it's the fact that we're improving inflammation, and because we're improving so many different things, everything just becomes so much better.
It gets me thinking a lot about it though, because I think when you see the impact of lowering inflammation through this pharmaceutical drug, it just begs the question of like, why aren't we saying where's the inflammation coming from? What else should we do? And I think there's just so much like, we're really getting off script here, but like so much systemic impact of our health, our policies around food and what types of food are available to people or are affordable for people. And it's really an interesting conundrum we're in right now where you have this, like, I'll call it a quote unquote miracle drug. Like you're seeing just tremendous results with a jab once a week or an oral medication. But like what I put my root cause hat on from a system perspective,
But
it
why?
almost buys
Yeah.
us time to not fix the real root problem.
Mhm.
I don't know. It's like
100%.
I have such mixed feelings around GLP-1s because I do think they're like miraculous to transform health, particularly for people who've struggled. And I hear doctors like you who are doing it the right way. But I also think about how many doctors don't have the time to do it the right way.
So this
Um,
is 100%, and I understand exactly where you're coming from because first of all, the question is why. That's the when I see labs, the next question is, well, why? Like it's not just oh, okay, your thyroid is off, but why? But why is your thyroid off? Like, but
yes,
why are things happening, right? So
we
that's my
love
question.
why.
Yeah, but when it comes to GLP-1, I think they're very helpful. But again, they're an adjunct to everything else that I'm doing, right? Like we're adjusting the diet, we're adjusting the lifestyle, we're doing all these so many tweaks, we're balancing your um your nervous system. We're doing so many different things at the same time. And then we're like, oh, and then now you can take this because now everything will work 100 times better while you're
Hmm.
doing all the things that you're doing, right? But it's not a crutch. And I totally hear you. It's not an excuse to go eat McDonald's and have French fries and now take your GLP-1. It's not going to work that way, right? But it is helpful when you're in the right context, doing everything appropriately.
Oh, I 100% agree. And I don't even know that I think of it as like people are using it as an excuse to continue unhealthy behaviors. I actually think that it can be really motivating for patients who've felt stuck at a high weight to start to get, I mean, like how many doctors, if you deal with someone who's obese, how many doctors have said, well, eat healthier and start to exercise.
Yeah,
But
yeah,
when you're like overweight, uncomfortable, in pain, inflamed, you're maybe depressed. Like it's this the obesity is not just your size or your weight, it's like a whole inflammatory
it's a
experience, right? So
correct.
I do think that and I've talked with a lot of clinicians who are using a lot of GLP-1s in practice. Some of the beauty of it is that patients come in having received this advice and been unable to action it. But then when they go on a GLP-1 for a couple of months, they start to lose weight, their confidence improves, their pain
Yeah,
goes down, they feel less inflamed, they can make better food choices because the food noise is down. Like I do
right,
think that it's such an opportunity, which is why I like
right.
talking with docs like you because you get it. And I can tell you're like, well, then we fix gut health, then we fix
Yeah,
lifestyle. And I wish that we could institutionalize that for everyone before we start to see more and more people on GLP-1s to manage all these things.
yeah, yeah. Look, I think it's very helpful. 20 years from now, 30 years from now, when we have way more data and studies, hopefully everything is only better. But there might be some things that are coming out from them that we are like, okay, I don't like the way this is going, right? Already, I will tell you, like, I use it in my patients, especially when I suspect there's addictive like behaviors, especially when it comes to alcohol or
Mhm.
cigarette users. Some people, when we give them a little bit of GLP-1, they do so much better because again, it's not just food noise, it's just cravings, right? So
Right.
yeah,
Anyway, there's so many different applications. We could talk for
I
days
know, I
about this.
know.
I do want to talk about a couple of specific updates. Like we're now seeing oral GLP-1 options come to market. Does that formulation like change who you think of as a candidate or who you might approach to take a GLP-1 now that there's options that are non-injectable?
Yeah, actually, so a lot of my patients, no, let's be honest, who wants to inject themselves once a week? Not everybody wants to do that. And so some people don't feel comfortable. It's not pleasant. Let's be honest. So I think it's a great option for people who want to lose weight, still get the benefits of GLP-1, but it comes in oral medication, right? I will say though, the data compared to the injectables are not as great, but it's a great option that's still available.
Do I would imagine there's also some patients who are like, "Oh, no, no, I don't want the oral. I'm happy on the injectable because it feels more potent."
Yeah.
And if they're willing to get over using a needle, which Lord knows how many meds are going to open up to us now that patients are comfortable with like sub-Q injections. It's pretty amazing.
Yeah.
But I think about that some patients don't want to move to an oral, even though it's another effective option because it
Yeah, I
doesn't
think
feel as potent.
yeah, and I think also for some people, they like what they like. If they've
Mhm.
been on the injectables, they're like, "It works." Like, if it's not broke, why fix it, right? So, I totally get that.
For the clinicians that are listening, like, what are the most common GLP-1 meds that you are prescribing? And is there a time where you choose tirzepatide over semaglutide, or do you predominantly go with one in your practice as a first line?
I used to use a lot of semaglutide, until tirzepatide came out, and that was just because, tirzepatide wasn't available a few like 5, 6 years ago. So I do like semaglutide, but, I do see more side effects on semaglutide.
Yeah,
So
me too.
so I do like tirzepatide a lot better now. There's less side effects. There's like maybe they'll be a little constipated, but not as much as when they were on the semaglutide. So from a side effect profile, I like it. I tend to notice that tirzepatide is a little bit more effective because you're getting the 2 peptides versus semaglutide, which is 1. So I can't wait for more data on their 2-tide. I mean, I'm excited about it because I think it's gonna be even better, clinically versus, just semaglutide alone. But I do like as of now, I do like a lot of, tirzepatide, Zepbound, Mounjaro, if I'm able to get my hands on it or my patients are, like, that is one of my favorite. But I also, if it's a financial thing, we'll let them try semaglutide. It's still cheaper. Now it is, versus their tirzepatide, so
Mm.
we give them all options and help them make the best decision.
That's great. I know that in our field especially, you're hearing a lot of talk about microdosing GLP-1s as well, which it's kind of a mystery. There's like a shroud of mystery around like what exactly is microdosing. From what I've seen, generally, it's just low dosing, really. It's like using 5 milligrams, or is it micrograms or milligrams for tirzepatide? Five
So
milligrams,
so we do a different thing. So typical starting dose for tirzepatide is 2.5 milligrams.
2.5.
Right,
Yeah.
so we'll go low, we'll go, like, 0.5 milligrams just to kinda see how they do, and then work our way up, if they need. And with the microdosing, sometimes I'm microdosing once a week, sometimes I'm microdosing 2 or 3 times a week just to see, like, what they need. Here's the thing with, the GLP-1s, we know that they have a half-life of a week, which means by the end of that week, you're hungry again, and it kind of is essentially out of your system, right, theoretically. This is why sometimes we will microdose it at lower doses, so it's constantly in their system at lower doses. So it's like 2 or 3 times a week you might be getting the same injection, but it's so low dose that usually by day 3 or 4, if you feel like the hunger pangs are trying to come back, you're giving yourself that next small dose injection so that you're still getting still curbing the appetite, still quieting that food noise.
Yeah, I mean, it makes a ton of sense. I always think about like I tell my patients, like if you think about the bell curve of like the medication comes up in your system and then it comes down in your
Yeah,
system. And when you're right, when it's coming down, symptoms can start to come back for some people. So essentially the area under the curve would be about the same, but you're taking like half the dose twice as often. So
right.
that, as it starts to come down, the next dose is coming up. And overall, it helps you reach more of a steady state. If you're not seeing me with my hand motions, I'm like so French Canadian that I'm like, if you guys are just listening, you can imagine me waving my hands around to try to demonstrate this, but it is a nice way to kind of even out the dosing,
Correct.
so you don't get the lows and the highs of a 7 day. And I think that for people who don't mind sticking themselves more often, then it's a really nice option to do that.
It is a nice option. It's very effective, especially clinically in our practice. But again, you're right. Not everybody wants to stick themselves more than once, and so
Mhm.
yeah.
Now, when it comes to the conditions beyond weight, you mentioned asthma as one that's like pretty exciting. Are there other applications that you're thinking, especially for women, this is going to be a game changer or something that you're really wanting to see what happens?
Oh, one thing that I'd love to see, I don't think it's there yet. And I think that's where like that diet piece. I'm kind of curious. Like we know that okay, it helps with inflammation, and that's why it helps with the asthma. For a lot of people, and sometimes just losing weight helps with breathing better, right? But I'd love to see. I'd love if it would reverse autoimmune conditions, and I haven't seen that yet, not clinically in practice, but like I have a lot of women that come to me that have you know autoimmune like lupus or autoimmune thyroid issues and I have not seen numbers drop from that. A lot of times if the number autoimmunity numbers are improving, it's because we're making more lifestyle changes. So I'm hoping maybe something will change there or, but who knows?
Yeah, there's a lot there. A lot of I'm sure in the next 5 to 10 years, we'll look at what we knew today as
Yes.
absolutely nothing compared to what we
Yeah.
know at that
Yeah.
point. I want to talk a little bit about life after GLP-1s because I think that's something that philosophically, like right away, you said, and then we take the patients off. And I think some providers view their patients as being on them really long term as a maintenance. Other providers want to see patients get off. And of course, it's up to the patient's choice and need as well. But we do know, like meta analysis shows what you said about your practice. When you discontinue GLP-1 receptor agonists, oftentimes there's a predictable weight gain. People regain about 8 to 9 kilograms. So it's about like 15 to 20 pounds after stopping. Cardiometabolic factors return to baseline within 1.5 years or so. And kind of the hormonal drivers of this, if they're not addressed separately, like
Correct.
you're talking about, the cortisol, the estrogen metabolism, androgen status, gut health, all these things rebound essentially to where they were. So, what is your concern? Like when a patient tells you, I want to come off a GLP-1, like what are the first things that you think about when they've kind of achieved their target goals? What are the first things that you're concerned about and you're thinking about for that patient?
So number one, of course, I never want to keep anybody on it forever. That's the first thing. So I do want them to eventually come off. Sometimes they don't want to come off, right? But I also think it's important to let the body take a break and let the body kind of recalibrate and kind of fix itself. Um, so we look at the whole picture, where they are, where their leptin level is, what their lifestyle is. I will also tell you, I don't think it's a good idea for me to take someone off of a GLP-1 between October to December 31st. Because of all the the holidays, the stress, the food, like, there's times where I'm like, let's take you off in January. How about that? Like, let's keep you on it for a few more months, and then let's take you off when we can control what we can control, right?
That's funny.
Um, so, like, even if there's, like, a lot of travel and stuff, like, depending on who they are, what they're doing, I look at the whole picture because if they're gonna be, traveling a lot for work for whatever reason, and they may not have the access to best food, like I would love them to eat, right? Then obviously, then maybe me taking them off of GLP-1 at that time might not be a great option. So it's like looking at the whole picture. But theoretically, we want to make sure that again, we optimize their diet where they're getting enough protein, so that they're also eating protein off of the GLP-1, right? The other thing that I will say is I always make sure that they're getting enough fiber in their diet, making sure they're getting good quality fiber. They're having really good regular bowel movements. We're stimulating their bile acid production, which produces GLP-1, giving them polyphenols, making sure they're getting healthy fats in the diet, encouraging like a nice Mediterranean style diet. So, again, going back to the lifestyle, if we can we work on that? Great. If we can work on that, let's get you off. But if we can't work on this piece because everything is chaotic around us, maybe we keep you on it a little bit longer.
Yeah, that makes a lot of sense. And when it comes to the weight gain that you typically see in practice, do you think a lot of that are the hormonal drivers kicking back in, or is it like hunger driving behavioral change and just eating more food generally, or is it some
I
kind of
think,
combination of factor?
I think it's a combination of things for sure. But a lot of times, if you, or not you specifically, but like the patient never really learned how to eat properly while being on a GLP-1, they're going to revert to bad old habits. That's just what it is. Like they're going to want to crave. They're good when those craving comes back. It might be like, okay, yeah, I want that donut, even though I haven't eaten donuts in 6 months. Like I want that donut.
I can relate to that. Donuts are like the world's best foods. So tell me a little bit about like when we were looking at talking about Dutch testing, are there things in the Dutch test that you think we should definitely look at this before you're on a GLP-1, during, or as you're getting off? Are there elements to that that you're wanting to measure at that time?
I love looking at the estrogen metabolism. Like that to me is like really important just to kind of see like what the breakdown is doing. Looking at the beta glucuronidase, that gives me an idea again what's happening in the gut, but also what's happening from a metabolism perspective. So I do like looking at the estrogen metabolites for sure, to kind of gauge what's happening. Also cortisol. Cortisol is the other thing that I'm paying attention to, like what's happening with our cortisol curve here.
So tell me a little bit about like your going off a GLP-1 plan. Do you and I don't think this is something that I've seen a ton of advice on. Like, do you just discontinue it? Do you taper people down? You've talked about a lot of the nutritional pieces, but can you just share a little bit, like start to finish in your practice? What would you be doing?
Great question. So we do different things for different people. Some people just abruptly stop for whatever reason. If they run out, they're like, "Well, I want to just stop." Some people we wean them off, right, depending on their protocol. Some people, if they're microdosing, instead of taking 3 times a week, we'll have them take it once a week. And then I have some patients that will inject them every like twice a month or even once a month just to get a little bit of GLP in their system, but not needing it. So we kind of do different things for different people. Again, there's no wrong or right answer. I think we just don't know, right? And so it's kind of like trial and error what works. Also from a financial piece, right? Like can people how long can people afford to take this medication for, right? And so we work with the patient to see what makes sense. And I'm also listening to them because I sometimes they're like, "Well, I need a little bit, but I don't need to take it every week. I want to take it every other twice a month, every 2 weeks. Let's try it. Let's see how do you feel. Are you maintaining your weight? Are you gaining weight? Are you losing weight? What's happening?" To determine like what's the best protocol for them.
That's awesome. I mean, you have offered so many great insights for this area of medicine. And I think it's only going to be an area that continues to grow in the number of applications we can use. So I'm really grateful to you for coming on today to really kind of sing the right way to do it ultimately, which is that this is not a standalone. There really shouldn't ever be the only thing you're doing for a patient. I mean, you're taking such a comprehensive approach. It's refreshing to hear.
Thank you. Thank you.
What advice would you have for providers who are really wanting to make sure they stay on top of the literature or the information around this? Like how for providers that are listening that want to be practicing more like you are, what advice would you give to them?
Just stay on top of the data. This is like a very new medication. Like sometimes, like I feel like I'm hearing things late because like information is coming so quickly at you. You have to, like for me, I'm constantly researching like what are the new updates, right? Because like there's a new study. I just learned about the asthma study like literally last week, it's just you just have to be on top of
Mhm.
it. That's the first thing. And then the other thing too is don't just think that your job is done because you wrote the prescription. Just because you wrote the prescription, that's just the beginning of the problem, not the problem, the solution I should say. You have to talk to them about the diet. You have to talk to them about their lifestyles. You also have to talk to them about their ultimate goals. It's not just, okay, lose 20 pounds. In our practice too, we look at body composition. So I'm getting a body composition before they start and during the weight loss process. I can tell you stories of patients that they get so excited to me. They're like, "Oh my God, Dr. Bindiya has lost 30 pounds." And then I get them to step on the scale and I'm like, "Okay, but you just lost 30 pounds of muscle. This is not the right way to do it." And then
Mhm.
they might get upset at me because I'm like, "We're going to stop the GLP-1. This is not now you're going to be sarcopenia. Like, this is not what we're trying to accomplish here." So it's not just writing the prescription, it's having the conversation, looking at all these metrics and information to determine should they still be on it? Should we take them off? Like, what are the long term ramifications of this? It's not just looking good in a dress. Yes, I want to look at a dress too. I'm there too. But if I don't have any muscle, and I have more fat now than when I started, we're in trouble.
Well, and I just think about you look like sarcopenia and also osteopenia, like osteopenia,
Yes. Yes.
osteoporosis. Like
Yeah.
I think that as a culture, especially right now where we're in the beginning stages of GLP-1 use and there's not a lot of providers that are doing robust protocols that protect lean mass, even though they know that that's a risk, we better get good at treating bone health for women later on in life because I think we're
Yeah.
going to have an upswell of that in our practices as
Oh,
well.
100%. Like, I already see that now in a lot of my patients. Like, I just found out that I'm osteopenic. Now, I had a suspicion because I have celiac. Unfortunately, I had the risk factors. But it wasn't until I broke my foot a few months ago and I went to the orthopedic doctor and I was like, "Do you think that I have, looking from the x-ray, I looked at the x-ray too. I was like, it doesn't look like I have osteopenia or osteoporosis on the x-ray, but do you think I should get a DEXA?" And they're like, she's like, "No, no, you're fine. You're good." And I'm like, Really? So I ended up getting a DEXA on my own, and I was like flabbergasted. I was like, of course I'm osteopenic. I have celiac, right? I already know my risk factors, but I'm also one of those women that are like lifting heavy, intentional, eating a lot of protein. And so then I'm like, this like is so messed up. If I have osteopenia, can you imagine like the rest of the women out there that are walking around thinking that they're doing all the things perfectly fine and potentially have osteopenia?
I think this is such an important conversation to have because like you did it on your own. I've done it on my own. They can do like a DEXA scan. Usually these clinics are like walk in, they're 50 to $100. It's not a lot of money for a scan. And they do a DEXA scan and then they normally do like your VO2 max. Like they monitor your breath for a period of time. They tell you a little about your metabolism. And those two things packaged are like maybe $100 on that first time special, any major city. And I know that when we look at DEXA scans, they're still saved for women who are much older. And it doesn't it's worrisome to me because I think there are a lot of women like you. My bones are strong. I was definitely built that way, like that big boned kind of body. But I do think that so many women are missing an opportunity to know. And this is when we get into like the functional integrative approach versus conventional medicine. Conventional medicine is based upon population percentiles and how you can get a cost-effective diagnosis, because you have the cost of scans for, millions of women versus the cost of treatment of millions of women. But that's looking at it on a population scale. It's population-based medicine. And I think that's where, when I think about it's not a right and a wrong, but for people who have the resources and who feel like population-based medicine isn't enough, that's where this personalized medicine approach comes. And I think it's a hard because sometimes it feels like, I don't know if you feel this way when you're talking to colleagues, like you're almost speaking a different language where they'd be like, oh, you don't need to do a DEXA scan for someone under 60.
Yeah. And
Why
I
would you ever?
Yeah, I listen, I've read the studies, I know the data, I know the recommendations, but I also will tell people, including my patients in my practice, I understand that insurance won't pay for this until you're postmenopausal. That's when
Mhm.
I could send it to insurance and it'll be free, but pay 100 bucks out of pocket in your 40s. I'm 43, right? It's so worth it at 43 to know, oh, I'm osteopenic right now, which means I'm going to even work 10 times harder on my bone health right now. I don't want to wait till I'm 60 when I have osteoporosis. I'm trying
Yeah,
to prevent that, right?
totally. Preserving health is always,
Correct.
always, always easier than trying to like regain it when you're not well. So I mean, we so speak the same language here because I think, I'm in my mid 40s as well. This is the time of life where like if you have the resources, get a baseline. And this is where there's this pushback on labs. You don't need to do all this testing. You don't need to do the hormone testing. You're right. To meet diagnostic criteria, you don't need to. But wouldn't you like to know what your blood glucose was 5 years ago or your insulin was 5 years ago compared today? Because ultimately, it's the change that we are concerned about, and you can't monitor change in a single time point.
The- I- and this is why, like, all my patients, like, even when I review labs with them, it's like a long appointment because I'm tracking, like, oh, well, last year it was this, 6 months ago it was this. Like, we're tracking it, and we can see things either get better, things get worse. Oh my gosh, I really geek out when it comes to like data because I think it's so important.
Definitely. And I mean, getting back to the GLP-1s, I think what we're seeing in medicine right now is that they have really proven so far in research to be a really interesting therapeutic to almost roll the clock back on a lot of the progression we see for people, particularly with metabolic health, where we have the most data. But there's risks involved, but there's a lot of areas where it's making profound progress or buying time for people before they progress to like a really terrible disease state.
Yep, for sure.
Well, this has been a great conversation. Thank you so much for joining me on the podcast and for kind of riffing with me about the healthcare system. I think this is something that I think a lot of providers really resonate with, not just the use of these medications in a more holistic way that really thinks about the long-term health of an individual and how to do it right. But how do we fit this into a model that's not quite built for the way that we see things? That's not quite built for asking why, like you
Yeah.
said earlier. So really appreciate you being here and sharing your insights with us.
No, I really appreciate this. This is wonderful. And listen, if there's someone who's listening today who is learned something and can, talk to their doctor about maybe we should talk about our metabolism and how can I optimize my bone health or optimize my muscle mass? have that conversation. Hopefully, we're empowering you.
Definitely. Now, I know you're based in Atlanta. What are the best ways for people to connect with your practice or just connect with you online?
Yeah, so you can follow me at Dr. Bindiya MD. It's my first name, BINDIYAMD, on all major platforms: Facebook, Instagram, TikTok, you name it. Our website is so my clinic is Revive Atlanta MD in Decatur, Georgia. And so you can just, Google it, Revive ATL MD. And you can also follow us on Instagram at Revive ATL MD. And yeah, I'm licensed in many states. So I can see people virtually. But yeah, come say hi. Tell me you heard me on this podcast.
Fabulous. Thank you so much, Bindiya, for joining me. And listeners, thank you guys for joining me as well. Hopefully, you found this conversation as fascinating and enlightening as I did. I want to remind you we release a new podcast every Tuesday. So if you want to talk more about hormones and about integrative and functional medicine, I hope you will join me next week. You can subscribe at any of the places that you can stream podcasts from, and follow us at Dutch Test on all the socials. Thank you so much. We'll see you next week.
Thanks for joining us on the Dutch Podcast. Join us every Tuesday for new conversations with leading functional health experts. If you like what you've heard, be sure to like, follow, and subscribe wherever you get your podcasts.